Good afternoon, Arun.
Yes, good. Wonderful seeing you. I just sent you a message. Welcome to this webinar. Yeah. Wonderful. Thank you. Thank you for joining in. Yeah. Nupur, can you take it over now? Yeah.
Or Francisco.
Nupur, you have the floor now. You go ahead now.
Okay. Yeah. Hello everyone. So just for information, I would like to tell you that we have around 150 participants with us right now, and it's increasing. So we should just start. Welcome everyone. I, Nupur Vidla, the Director Advocacy with Breastfeeding Promotion Network of India, will be your moderator for this webinar today. And I welcome all the panelists and attendees at the online launch of the WBTi Evaluation Report 2020. I'm happy to see you all. I'm happy to share that we've got an overwhelming response for this webinar registration. We got around more than 500 registration from more than 80 countries, which is quite good, quite a good turnout. And I would like to share that BPNI serves as the South Asian office for the International Baby Food Action Network and as the Global Program Office for the World Breastfeeding Trends Initiative. Now I would like to share something about some information about World Breastfeeding Trends Initiative as the program. So WBTi is a flagship program that tracks and monitors policy and programs on breastfeeding and IYCF at the country level. It measures implementation of the global strategy for infant and young child feeding in a standard way. It was launched in the year 2004 and 5 from South Asia, and it went on to become global in the year 2008 and 9. We have trained more than 120 countries on WBTi, out of which 98 countries have already reported. WBTi as a tool has been recognized by WHO and UNICEF's Global Breastfeeding Collective as one of the 7 actions to drive progress on breastfeeding to raise the global rate of exclusive breastfeeding to at least 50% by 2025. WBTi has a web portal that has open access to data from 98 countries on policy and programs on breastfeeding and IYCF. Now I would like to share my screen with you all to give you a little demo about our portal. Okay. I hope everyone can see my screen.
Yep.
Yeah. So here is the website. The website is called worldbreastfeedingtrends.org. And here you can see all the tabs. It has information, it has resources. It basically has a list of all the 98 countries who have reported on breastfeeding policy and programs. All these countries have done series of their assessments, and you can go and, for example, I'm opening Gambia for you here. So when you open a country, you can choose the year of their assessment. So like for Gambia has done 2 assessments, one in 2008 and another in 2016. And then if you scroll down, you can see their scores on all the 10 parameters of breastfeeding, infant and child feeding policy and programs. So this is how you can access. It is open access for all. You can go and access this web portal and can have information on policy and programs, report cards. You can compare countries on this web portal, and you can also find a lot of resources that you can find the WBTi tool, the guidelines for scoring, the guidebook, various publications that we have. I'll stop sharing my screen here. Okay. So today, to start the discussion, I would like to share that we have a panel of global experts on infant feeding and nutrition with us from around the world. It's a great opportunity for all of us to understand how to track and monitor policy and programs on IYCF and how that can stimulate national action and can lead to improved policy programs contributing to improved breastfeeding rates. I take immense pleasure in introducing our esteemed panel with you. Today we have Dr. Arun Gupta, MD, WBTi Global Secretariat, Delhi, with us. He'll be sharing the key findings with us of this program. Then we have Dr. JP Dadich, Technical Director, BPNI, Delhi, India. He'll be sharing the challenges, lessons, and recommendations from the evaluation report. Then we have Ms. Barbara Nalubanga from IBFAN, Uganda, Africa.
We're still waiting for her, right?
Waiting for her, yes. We do have a presentation, like in case if she's not able to join, we can do it. Yeah. So she'll be sharing Uganda's WBTi experience and how government considered the report and how it helped them. Then we have Mr. Marco Serrana from IBFAN, Mexico, Latin American Caribbean region. He's going to share Mexico's experience on what value WBTi added to their national IYCF work. Then we have Naomi Hull from WBTi Australia. She's going to share Australia's experience of WBTi on its assessment and its impact at the country level. Then we have Francesco Branca, Director, Department of Nutrition and Food Safety, NFS, from WHO headquarters, Geneva, with us. Is going to share remarks and way forward to increase global rates of exclusive breastfeeding from 41% to 50%. Last but not the least, we have David Clark from UNICEF headquarters, New York, and he's going to share how WBTi is integrated in Global Breastfeeding Collective and in CRC reporting. So we're going to start with Dr. Arun Gupta, where he's going to present some key findings from the evaluation report. Over to you, sir.
Thank you very much, Nupur. I just heard Barbara has also joined, but we are unable to see because of the long row. Welcome, Barbara, and welcome everybody once again. Thank you very much for accepting this invite to this webinar to launch this evaluation report. So very quickly, I'll move as Nupur has already introduced WBTi to you. I'll very quickly share what this actually is about. Based on the WHO's global strategy and the tool for national assessment of policies and program, WBTi works for tracking policy and programs at the national level. In its 15th year now, what WBTi did to the tools, existing tools, was it adapted them and added values like scoring, color coding, reporting, galvanizing national actions, and creating a global repository, which Nupur just showed. So WBTi shows what works and what doesn't work. So that's the value which WBTi brings to the national governments to think about initiating more action. How it is done at the national level, this process is the key of WBTi, and Dr. Dadich later on will share with you the detail of the process. So while we entered into this evaluation when 97 countries had completed this work and reported, so we thought of this doing this study with the objectives to assess the difference WBTi is making at the national level, to analyze the factors associated with the use of WBTi report and report cards, and then assessing how WBTi results have been used in the countries to impact action there. I'm finding a difficulty in moving my slides. Hello, I'm just stopping to share again. I have to move. I don't know what happened, but the slide.
Screen again. You can try sharing your screen again.
Okay. Yes. All right. Can you see this?
Yes.
Hello? Okay. Yes. So we use the following methods to do this evaluation study. Briefly, I'll let you know. First of all, we constituted a global technical working group from 5 countries in the different regions who drafted and then helped in field testing the questionnaire. Once this was finalized, we went into the phase of data collection in 2019, where we shared this tool with 97 countries, and then we used the information provided by them, did the analysis, both quantitative and qualitative, this tool, and most of this work, analytical work, has been done. Thank you, Uganda, IBFAN Uganda, for this. So I'll quickly move on to the quantitative part of the results. If you can see, 51 of the 97 countries responded from all over the world, from all the regions. And what I said in the beginning, the key process is formation of a core group in every country, and that too without conflict of interest as a guideline we serve. If you notice that this core group consists of varied individuals from different agencies like governments, academic institutions, UN, breastfeeding groups, sometimes individuals. So different types of people join the core group, usually led by IBFAN in about half of the cases, and in 1/3 cases it's been led by governments in Africa and in Asia. So this core group is the key in doing the assessment, in sharing the assessment findings with the governments and further work, which makes an impact. So in the following slides, you will see what other thing this has led to. So what the WBTi work in the country, we found that it helped in strengthening the skills of the WBTi coordinators themselves. So 44 out of these 51 countries that reported they learned report writing, 34 research methodology, and large number of them, 40, that they did analysis, they learned analysis of data. So these are the skills which are important. They stay, they contribute to sustainability, like organizing a meeting and a workshop and using advocacy skills for making a change. Similarly, if you look at the organizations part, where we find that two important things reported by the organization which led this work in the country, they reported that they act recognized as a reference point for infant and young child feeding and breastfeeding issues. Secondly, majority of them reported, 35 out of 51, they serve as a platform for local partnerships around infant and young child feeding. So this is something again which contributes to, there are several other skills we can find in the report, which is right on our website now and will be shared, the links will be shared later also. Now, key results. The two things which come out of the assessment, and the core group is responsible along with the global secretariat, is a country report and a country report card. These things are used formally in almost all countries. If you see, 96 to 90% people reported that they produce these formal reports and report cards. Now, what prompted action? The coordinator and the core group took these report cards to, in case of 73% took to a policymaker for a meeting with a policymaker. Then they more than 65% took to a conference, to a meeting of the partners with 63%, and more than half they also shared the reports through emails to national people, concerned people in the country. So all these actions combined or alone actually made a difference when it comes to presenting the analysis to the governments. What role IBFAN played? You will see here in the 70% cases, IBFAN played the role for report development. Assessment contributed to about 2/3. In report dissemination, same, and it contributed half the cases for advocacy and several other. Again, the details are given in the report. When you have a report in your hand, you can see it. So, and this analysis and reports, they prompt the 2/3 of the governments to commit or take actions. This is very important. So, in all the four, there many countries did 4 assessments. If you see in the first assessment and the second assessment, about half of the governments, they committed or took action. In third and the fourth, this came up to about 75 to 80%. So on an average, so this is very encouraging that this analysis and reports are helping the governments to make commitments, recognizing the findings and the credibility of these findings. There are several other gains also, which I'm sure you'll hear more about. CRC reporting from David Clark, and in many countries also, about 1/3 of them reported added funding to their work in terms of breastfeeding work. And capacity building of health worker skills was very common reporting from almost all countries. That this is something which was initiated or rejuvenated in that sense. Now coming to the crux of this is that WBTi as work leaves behind a very sustainable work program called Sustainable Core Group. What do they do? The 65% people reported that the core group is still active, working, and what kind of different kinds of work they do, reconnecting with the organization. They have already worked in the core group or others, with the government people, policy makers, asking the governments to organize. Some countries lack data, so they ask them for data collection, dissemination of knowledge. They're involved in evaluation research, and several of them have actually written papers and published them. 10 of them have published them also. So many of them have been active in the code, reporting on code violations. The conference I've already shared with you. Now, what we are learning from this is that the periodic monitoring, which is recommended by the WHO and UNICEF, the Global Collective, and we have been recommending it right from the last 15 years, is the key actually to improve policies and programs. In this figure, if you see the 10 countries who did 3 assessments, they are shown in terms of how much gain in the policy score they achieved. If you look at this red line, the percentage, barring these 2 countries who did not gain a score, all those countries from minor gains to gains in Afghanistan with more than 100%. In terms of Bhutan gaining about 70%, Dominican Republic and Nepal also gaining about 70-75%. So this is something which is important to take note from this report. Similarly, just emphasizing further, if you have 4 countries who did 4 assessments, now you see India did not make much change, and the rest, the 3 countries here, Bhutan, Nepal, and Afghanistan, if you see, and almost touching 200% gain in this, if they repeated the assessments. Just simple presentation here to show how from 18% in Peru, El Salvador 35%, Dominican Republic 69%, Bhutan and Nepal 75%, and Afghanistan gained 196% in the policy scores. So this is something which I want to highlight with the specific policies. We found further analysis revealed that several policies were more importantly received attention. For example, infant feeding and HIV. It received quite a significant attention, in this repeated assessments, which followed. And then we have maternity protection, the first indicator, the policy coordination, and then others like mother support and HIV also gained it. What is unfortunate here is, and very clearly found in this report also, BFHI has lost out in this whole assessments in the last 15 years. We found if IFE, infant feeding and emergencies, gained 158%, and maternity protection gained about 58%, and so is the policy and funding, etc. But BFHI declined by 21%, which is something I think requires much more attention, so that it makes, going by the country, I'm just giving you a few examples of how each country, we did the analysis, which are the policies and programs they gained from. Afghanistan gained in policy, legislation on the code, and infant feeding in emergencies. Similarly, if you look at Bhutan, policy, maternity protection, monitoring and evaluation, look at it. Similarly, Dominican Republic and El Salvador also looked in monitoring and evaluation in both in infant feeding and emergencies, as well as maternity protection. So law again comes back in El Salvador also importantly. So this is something which we need to keep tracking on. Now, finally, when the policies gain, they do result in higher rates of breastfeeding and infant feeding practices. Here, I like to draw your attention to initiation of breastfeeding, which gained about 96% from 26 to 52 in the repeated 3 assessments. In exclusive breastfeeding from 33 to 48% in the 3 assessments. Then I take on to complementary feeding from 55 to 73. What we have find here is bottle feeding also increasing, which probably may have been related to BFHI being not getting the right attention, and bottles are introduced or formulas are introduced. But this is something which we need to look into future. Thank you very much for your attention, and I hope to hear more questions from you. I will be happy to answer.
Thank you, Dr. Arun, for sharing the key findings. Now, I would like to introduce Dr. J.P. Darij, Director Technical, BPNI Delhi, India. Dr. J.P. Darij is ND, is a senior pediatrician, a fellow of the National Neonatology Forum. He's associated with BPNI since more than 1.5 decades. He is the co-chair of the Global Council of International Baby Food Action Network. He has several publications in the peer-reviewed scientific journals. He has contributed to several guidelines and chapters on breastfeeding and infant young child feeding. Over to you, Dr. JP. He's going to share the challenges, lessons, and recommendations from the evaluation report.
Okay, sorry, I was muted actually. So my screen is visible, Nupur?
Yes, yes.
Yeah. So thank you very much, Nupur. Depending on your location, friends, good evening, good afternoon, good morning, because we are having participants from all across the globe here. After listening about the key findings of the report from Dr. Arun, let me share the challenges encountered and lessons learned by the country groups while undertaking WBTi assessment work in their respective countries. I will also share some recommendations based on the findings of the report. But before I talk about the challenges, I also stuck here, so I have to stop it and then.
You have to stop and reshare.
Yeah. It's not moving. Mm-hmm. Yeah. So before I talk about the challenges and lessons, I will touch upon the WBTi assessment process in brief. This will be helpful in understanding the challenges and lessons shared by the respondents. There are 3 steps in the WBTi process. First being identification of the country coordinator for WBTi, constituting a core group, and developing a draft report using the WBTi tool. The second step involves discussions on the draft report by national partners in a meeting in which the report is finalized. This is submitted to WBTi Global Secretariat at BPNI. And after verification process, the report is uploaded on the WBTi portal where scoring and color coding is done. And then comes the step 3, in which report and report card and call to action are disseminated and used for advocacy. The same cycle is repeated every 3 to 5 years. And all these 3 steps, they contribute to improving policy programs and practices. So now we come to the challenges. So what were the challenges reported by the respondents? To know about the challenges, the study tool included a specific question, and that was, what were the major challenges in applying WBTI at country level? The information obtained from the respondents about challenges was synthesized under 4 key themes. Number 1, leadership and governance. Number 2, financing of WBTI process. Number 3, health information system. And number 4, sustaining the WBTI work. We will look into them one by one. In the leadership and governance and health information system, countries found challenges like it was difficult to involve the Ministry of Health and other government authorities in the core group. There were frequent changes of the authorities at policy level, requiring renewed advocacy efforts. Then it was challenging to make IYCF a priority at political level. Then it was challenging to reach to an agreement on recommendations among the WBTI core group, and sometimes it required extended discussions to reach to a consensus. Then lastly, in the health information system, it was difficult to procure data as some countries did not include IYCF practice indicators in the national health surveys. Also, qualitative information to answer subset questions in different indicators required a lot of efforts. In the financing and sustaining of the WBTI process, respondents reported absence of budget lines by the governments and a lack of interest by the UN agencies to provide financial support for WBTI. These factors led to financial and human resource limitations to undertake the WBTI assessment process, to print the report and report card, and to host a dissemination meeting once the report is ready. A number of respondents reported difficulty in sustaining the WBTI core group after assessment is completed, which is so crucial for advocacy with the governments to strengthen policies and programs. Apart from the challenges, respondents also shared some positive lessons learned by them through the WBTI assessments. To know about the lessons learned, the study tool included a specific question: what major lessons have been learned from applying the WBTI process at national level? And the responses were arranged under 4 key themes. Number 1, policies, program and funding. Number 2, collaboration and partnerships. Number 3, priorities and strategies. And number 4, surveys and reporting system. Let us see them one by one. The first lesson was WBTI helped in improving policies and programs on IYCF and funding for implementing them. WBTI made it possible to objectively identify gaps in policy and program implementation, and it was possible to motivate country governments to bridge the gaps thus identified. The WBTI process helped raise issues needed to enhance commitment of decision makers. The WBTI report and report cards using color coding had a better visibility and were useful and effective tools for advocacy. Second lesson respondents learned was about the role of WBTI in improving collaboration and partnerships. It was noted that building strong partnerships and ownership of the WBTI process by the concerned actors was possible. In the process, country-level actors without conflicts of interest, including government agencies, UN agencies, professional organizations, civil society, etc., they became partners for the cause of breastfeeding, and this country-level integration of different sectors and strengthened interinstitutional coordination led to capacity building in protection, promotion, and support of breastfeeding among different players. Third lesson was about WBTI's role in development of priorities and strategies for strengthening policies and programs on IYCF. It was noted that WBTI process generated evidence-based information which helped in identifying weak areas in the policies and programs and prioritizing and strategizing the action on IYCF in the country. And lastly, WBTi assessment helped in identification of gaps in data collection system. It was instrumental in governments taking action for improving national surveys for better infant and young child feeding practice data, and governments taking action for improving monitoring tools, reporting standards, and processes. Based on the findings of the study, some recommendations were synthesized by the research team. Number one, the government, UN agencies, and donors should prioritize monitoring and tracking of IYCF policies and services through WBTi as one of the important strategies for improving policies and programs on IYCF. Two important ideas for this are strengthening the work of core group and providing funding for the WBTi process. Second, governments should provide specific funds through a budget line on IYCF for implementing IYCF programs in the country. Number three, all countries should learn from the WBTi process and undertake the WBTi assessment. So far, 98 countries have done at least one WBTi assessment. Countries that have not yet adopted the WBTi should learn the process and do the assessment. This will help in identifying gaps and catalyzing action to bridge the gaps in the IYCF policies and programs. Lastly, those countries that have already done one or more WBTi assessments should do periodic reassessment every 3 to 5 years. This will help in recognizing the progress and need for further action. So this is all I wanted to share with you. I stop here. Thanks for your kind attention. Thank you.
Thank you, Dr. JP, for the presentation and letting us know the challenges and lessons and recommendations. Now I would like to introduce Barbara Nalubanga from IBFAN, Uganda, for the next presentation. Barbara Nalubanga is a senior food and nutrition specialist with a degree in food sciences and technology, with post-training in food and nutrition security and project management. She has 24 years of experience with the public health sector, humanitarian agencies, several non-governmental organizations. Ms. Nalubanga has been actively involved in professional networking with Uganda and the African region. This experience includes building successful partnership with governments, NGOs, and research institutions, and the United Nations. Ms. Nalubanga is currently based in Uganda, working with International Baby Food Action Network Uganda, while providing oversight to IBFAN Africa Regional Office. She's also one of the co-chairs of the IBFAN Global Coordination Council. Barbara, over to you. Can you listen to us?
Yes. Can you get me?
I would request host to please screen share Barbara's presentation.
Okay, thank you.
Yeah, Yashika, if you can share your screen and showcase Barbara's presentation, please.
Yeah, just give me 2 minutes. Just give me 2 minutes. I'm just doing that.
Okay.
Can you see the presentation? Hello?
We can't see your screen. You have to share it. I think.
Yeah. I'm just doing that.
Share your screen, please.
Robert, can I try from this side? Or she's going to do it?
Yeah, maybe if you have it. I think there's some technical error we're facing. Maybe Barbara, you can try.
I'm trying actually. I'm trying maybe because of internet connection actually.
Okay, no problem. Barbara, you can try sharing your screen.
Okay.
Yep. Oh, we can see it. Yes. Yeah, we can see it now. You can just enlarge it if possible.
Barbara, can you
from Uganda?
Slideshow, please.
And this time I'm the WBTi.
Can you go to slideshow, please?
It's not slideshow?
No, so there'll be an option in the PPT where you can just click on the slideshow and it will be on the bigger screen. Yeah, so we can see the full slide. Yeah.
Yes.
Perfect. Perfect. Thank you. Yes, Barbara, please go ahead.
Sound like a problem in the we can't hear actually. Barbara, are you talking? We can't hear you.
Wow, can you hear me now?
Yes, now we can. But it sounds like either a bad internet connection or some technical problem. We can't hear you.
We can see, yeah, we can.
Can you see anything?
Now we can see your screen.
Can see the screen?
Yes, 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 we can see it. Go ahead, please.
Thank you. Uganda is one of the African countries with a total land area of 77,000 square miles. I'm saying this because we need to know the population size, which is really huge, 46 million individuals. Our fertility rate is 43, under 5 is poor. Prevalence of wasting. The breastfeeding situation in Uganda is as that between 2006 to 2016, initiation of breastfeeding increased from 54 in 2006 to 66 in 2016. Exclusive breastfeeding from 60 to 66. 2006 did not pick that, but 2011 picked it. It's still remained the same at 1 year, and 2 years dropped. Bottle feeding is improving, and median breastfeeding in months, 2006 and 2016, exclusive breastfeeding, bottle feeding, and median duration of breastfeeding, a decrease in continued breastfeeding.
I think there's some issue with Barbara's connection. Her voice is breaking. Can't hear her now.
The policies on IYCF for you. Breastfeed exclusively. For those mothers with low birth weight babies, they are categorized for those ones who can breastfeed, they should be supported, and those who cannot breastfeed, they should be supported to express breast milk and give it by cup spoon. Then there are those mothers who are living with HIV, they should be supported to adhere to ART and continue breastfeeding their children until 12 months of age. And then mothers and caretakers as well as families should be supported to practice optimal breast, infant and young child feeding in emergencies. One on Ebola, which has not been finalized. And now with COVID, there should also be one, and we are working on that next week. I believe so. We should have been able to incorporate it in the final document. The WBTi process in Uganda involved one person was trained in Swaziland from IBFAN Uganda. That person came back and worked with the National Infant and Young Child Focal Person, and these ones did the assessment in 2008, 2012, and 2015. So we've done so far 3 assessments in Uganda. The core group, those ones who participated were 32, and they are distributed as that, mainly from Ministry of Health and NGOs. The role of IBFAN was basically to provide financial and technical support. IBFAN built the capacity of the focal person and a team of experts to do the assessment, as well as drafting and finalization of the report. They supported government to do that. When you look at our performance between 2008 and 2015, you realize that between 2008 and 2012, we had improvement in policy, improvement in BFHI. It's interesting, from 2.5 to 6 out of 10. We had improvement in health and nutrition care system, mother support and community outreach, HIV and infant feeding, as well as M&E. We did very well because there were 6 indicators that we improved. But between 2012 and 2015, we had only 4 indicators that improved. And basically, it was trying to pull those indicators that had not improved between 2008 and 2012. And these ones were mainly maternity protection. Maternity protection was really challenging, and the effort was put in that. Hence, we left out some of the indicators. We did focus on some of those key indicators. The other one that we focused on was mother support and community outreach. Infant feeding in emergencies, as you realize, it had really dropped from 4 to 2. So in 2015, it jumped to 7. And then the monitoring and evaluation. So what you realize that the commitment from government led to the improvement of all these indicators between the 3 years. So because of those, the policies and programs improving, you realize that our breastfeeding rates are actually high. Our initiation of breastfeeding is actually high at 9, having increased from 6 in 2008. Exclusive breastfeeding has remained high. Median duration of breastfeeding is fair. Bottle feeding is still trying. Complementary feeding is still the same. We did our assessment in 2015, but DHS came out in 2016. That's why I had to put in 2016 to show that much as we did not capture complementary feeding in 2015, that was the time the DHS was being carried out, the survey was being done, and you realize that we scored really high for the timely introduction of complementary food. So as far as we are concerned, I believe we realize that focusing on policies and programs will have all these practices high up, and we pray that now that we have delayed in doing the assessment, has continued being high. The infant and young child feeding technical working group and the coordination is a little at a senior level in the sector. These ones provide feedback as well as ensure that they own the process. The nutrition technical working group, after approval of the report, sent it to senior management, and the senior management ensured that the findings were aligned to the policies and strategies, which I just mentioned earlier, and also approved the report. And on approving report, we had many changes. First, these are the improvement. The policies and programs showed some improvement, like we revised our policies on HIV and infant feeding, following the new WHO guidance. We also we had the child feeding incorporated into the action. We are working on the policies, workplace policies and practices at a different workplaces currently, and WBTi. When they were drafting action plan, they prioritized breastfeeding in it, and it's because WBTi provided the necessary information that was being used. The laws on maternity protection are being revised, and then the regulations on marketing of breast milk subsidy are being revised, because currently we cannot enforce the current regulations, because what was drafted there at that time cannot be used for enforcement. There's that the department indicated in the regulations no longer exists. So who is supposed to enforce this? So that's why we are not performing well as far as the code is concerned when you follow the WBTi. We have also developed the strategies and tools for improved infant and young child feeding by incorporating them in the overall guidelines of maternal, infant and young child and adolescent nutrition and action plan. Training manuals were done, and they were almost done and finalized for community and healthcare providers. And then the counseling job aids with strong component of IBFAN has also been finalized. There have been improved collaboration and partnership. We have a fully functional committee on nutrition, and they are basing this committee on already the legal aspect within our regulations, because there should be a committee. So these ones are covered under the regulations of marketing of breast milk substitutes. We have enriched surveys and reporting systems. And this one, JP has just mentioned it, from different countries. And then the capacity has been built for BPNI, the code, infant feeding in emergencies, and infant and young child feeding related surveys, where we are now looking at indicators on complementary feeding deeper than what they used to be. There's also building capacity of both public and private health facility in BPNI implementation. However, we still have challenges. One of them is the leadership at the district level for IYCF. In the national level, there's support, but when you go back down to the district, the support is minimal, because one, the leadership may not understand infant and young child feeding fully, and also the tool that we are using is more at the national level. So if we can adapt a tool that can be used at sub-national level, and then the information we get from them, we use it for advocacy at that level, we believe that we can address this challenge. The other way is sustaining the WBTi working group. This group was trained in 2008-9, and now they don't have much to do, because we have not done much, because there's no budget line for WBTi. And yet even we are supposed to be doing another assessment, but funds are not available. So that's where our challenge is. Thank you very much.
Thanks. Thanks, Barbara. Okay. Moving on further, I would like to introduce Marcos Arana from IBFAN Mexico, Latin America and Caribbean region. Marcos Arana Sereno is a Mexican medical doctor and anthropologist, researcher in the National Institute of Medical Sciences and Nutrition, Salvador Zubiran, and director of CCESC, Training and Education Center on Ecology and Health. He's also the founder member of IBFAN LAC, Sasakawa Health Prize 2005. He is the technical secretary of the Committee for Promotion and Protection of Maternal Health, Mexico. Marcos, over to you. Marcos is going to share his experience from Mexico, what value WBTi added to their national work, national IYCF work. Thank you.
Thank you, Rupur. See if
you can share your screen.
Yeah.
Yeah.
Okay. Thank you. So we are just over 12 years apart since the first WBTi assessment were carried out in the Latin American region. Now we can affirm that the WBTi contribute to have more complete diagnosis of the region, as well as to identify common problems, set priorities, design and implementing coordinated strategies. As we can see in the report presented today, in subsequent evaluation show progress in several countries of our region. That was the case of the Dominican Republic, Peru, and El Salvador. Adopted the joint effort of teams working that WBTi has galvanized has significantly contributed to these achievements. In Mexico, 2 WBTi assessments have been carried out in 2008 and 2015. The differences found between these 2 evaluations have made it possible to measure progress and highlight the critical issues in which no substantial progress had been made. The identification of these problems has also contributed to focus attention in some critical aspects, as well as to set national priorities, and WBTi has also helped to build important alliance at the national level. In 2015, the WBTi evaluation and the report made an important contribution for the elaboration of the shadow report that the Mexican civil organizations submitted to the United Nations Committee on the Rights of the Child. The two of the recommendations made by this committee to the Mexican state on breastfeeding and the implementation of the code were based in this report. One critical issue highlighted in the 2015 evaluation was the lack of guidelines and preparedness to assure safe infant and young child feeding in emergencies. This issue got the lowest score in the evaluation of 2015, but this point was especially critical since in 2017, during the emergency caused by the 2 strong earthquakes, the lack of national policy evidence in the evaluation led to critical situation. The report raised an important discussion about this topic, and now this topic is being addressed worldwide. In the countries of Latin America and the Caribbean, one of the virtues that WBTi has been especially recognized, its comprehensive nature, since it pursues a vision in which is not only constrained to the health sector, since it includes overall aspects like the maternity protection relating to the conditions of the women and their rights. WBTi monitoring of this area has also contributed to raise the interest of women's organizations. We have to say that many of them previously were not so interested in breastfeeding, but it has also stimulated them to come forward and to see with interest and see the progress and lacks in maternity protection shown in the WBTi reports. This has led also to build new alliances. The evaluation carried out in different countries in Latin America and the Caribbean together offer a regional vision that has helped us to analyze and compare, and has importantly contributed to the definition of advocacy strategies both at the national and regional level. In 2018, the Mexican government began a process of reviewing and consulting the national standards for breastfeeding, is el Proyecto de Norma Oficial. The dissemination of the results of WBTi report and has contributed to a large amount of comments and suggestions being sent to the authorities. And in this way, they are also contributed to the revision of this norm. Although the new standards has not been published, it has become apparent that the new standards will include specific measures to address the issues identified as critical during the assessment. WBTi assessment reinforced the need to eliminate the industry self-regulation and voluntary codes, as well, that was a common practice in Mexico, as well as to ensure that national regulations include provisions arising from resolutions of the World Health Assembly. The need for a permanent monitoring mechanism and the application of effective sanctions in the case of violations of the code. The establishment of a national breastfeeding committee free from conflicts of interest, with effective coordination and with the participation of civil society and academia, that meets periodically with a well-defined work agenda. WBTi was the first assessment and has inspired the development of other national and international evaluations of strategies that promote and protect breastfeeding. Personally, I think that these other assessments and scores are complementary. However, I see that WBTi as a fundamental evaluation process, which I would like to see sustainable with more international and national collaboration, with periodic evaluation at certain regular intervals. The benefits of WBTi instruments can be expanded to include other emerging topics such as the implementation of international guidelines for breastfeeding and COVID-19, among other issues. Thank you very much. This was the experience of Mexico, and we hope that we have future assessments of WBTi, which has proved to be very useful for the improvement of the global strategy in Mexico. Thank you.
Thank you very much, Marcos. It was well in time. Your presentation was well in time. Thank you so much. Next, I would like to introduce Naomi Hull from WBTi Australia. Naomi, you have in total 7 minutes to share your experience. Naomi Hull is a registered nurse and IBCLC and has a Masters of Public Health in Nutrition and the coordinator of the World Breastfeeding Trends Initiative Australia team. Her passion for breastfeeding and lactation began after the birth of her first child in 2001. She's an IBCLC since 2010. During her Masters of Public Health, her interest in the bigger picture grew stronger, and for this reason, she chose to look at the implementation of Australian National Breastfeeding Strategy 2010 and 15 as the topic of her dissertation. Under the mentorship of Associate Professor Julie Smith, Naomi brought together an awesome team of individuals to develop the World Breastfeeding Trends Initiative Australia. Naomi feels strongly about finding a way to ensure the protection and fulfillment of rights of women and children to access information and support of health and nutrition. Naomi, over to you. You have 7 minutes. Thank you.
Thank you, Nupur. Good evening, good morning, and good afternoon to everyone. It's after midnight here in Brisbane, Australia, but I'm very, very grateful and honoured to be here with you all. I would like to begin by acknowledging the traditional owners and custodians of the land on which I stand, the Turrbal and Yugara people, and pay my respects to their elders past, present, and emerging. I'd like to start with a very brief Australian infant feeding history. Australia has waxed and waned in its commitment to increasing breastfeeding rates since its lowest point in 1971. There were great signs in the 80s and 90s with the words promote breastfeeding as one of the first steps in the nutrition guidelines, and good financial investment in the 90s. Breastfeeding seemed to fade into the distance at a national level at the turn of the century, which motivated the Australian Breastfeeding Association to prepare the Breastfeeding Leadership Plan in 2004. This instigated a federal inquiry into breastfeeding, and the Best Start report was the outcome of this in 2007. In 2009, the next Australian National Breastfeeding Strategy was launched, but it went largely unfinanced and unimplemented for its 5 years of life. In 2017, Associate Professor Julie Smith brought together a group of approximately 30 clinicians, academics and advocates from around Australia for a gender budgeting and breastfeeding workshop. We were joined by Dr. Shobha Suri from IBFAN and Alessandro Elamo from Save the Children. By the third day together, our core team was formed. This is a portion of our core team. We were nearly all there in one place at one time. We had 11 individuals in our core team, including representatives from the Australian Breastfeeding Association and the Lactation Consultants of Australia and New Zealand. We also got together a reference group with about 10 individuals and organisations such as UNICEF Australia, South East Queensland Breastfeeding Coalition, the Breastfeeding Coalition of Tasmania, and Childbirth and Parenting Educators of Australia. All up, the assessment process took us approximately 6 months. One of the main difficulties of using this tool for Australia was that our health system is largely managed by states and territories. This meant that even if one or two of the states were doing the right thing and scored well on an indicator, there would be a 0 or low score if it wasn't happening in all the states and territories. Overall, Australia scored 25.5 out of 150, which placed us third last out of 97 countries at the time. Australia scored well on indicator 4 due to our reasonable maternity protection policies, and on indicator 6 due to the amazing work of the Australian Breastfeeding Association's 1,000 volunteers. Low scores resulted from lack of a nationally coordinated approach, lack of national policy, inadequate and inconsistent breastfeeding education for health professionals, an absence of supporting the needs of infants in emergencies, a lack of legislation of the World Health Organization International Code of Breastfeeding of breast milk substitutes, and absence of nationally consistent and reliable data collection and reporting on breastfeeding indicators. The WBTi Australia team recommended that there be adequate funding for coordination and communication on a national level of an infant feeding policy, as well as an infant and young child feeding in emergencies policy with the appropriate guideline documents. The establishment of a national breastfeeding and infant and young child feeding advisory committee, establishment of an independent WHO code compliant body to administer the Baby Friendly Health Initiative in Australia, ongoing adequately funded training of health professionals, to implement legislation to enforce the International Code of Marketing of Breast Milk Substitutes, and to establish a sustainable national data collection system using current global breastfeeding indicators. A unique strength of the WBTi process is that it's participatory and designed to galvanise advocacy and action. So how has WBTi Australia been influential? Our WBTi assessment report is the first in the world to embed an explicit gender analysis. IBFAN has moved towards incorporating the gender budgeting approach pioneered by our team to assist policy and program costing and advocacy for adequate funding. In Australia, the WBTi report and related processes and follow-up has influenced awareness, advocacy and action through those three processes. Firstly, Team activities have raised awareness of the problem among health workers, policy decision makers and the public through the use of communication in blogs, all social media platforms, relevant newsletters and academic journals. We've also done this via health conferences and workshop presentations, such as to expert meetings on the Australian National Breastfeeding Strategy. The WBTi Australia team won an award for Best Paper in the Advocacy and Leadership category at the National Public Health Association of Australia in 2018. And also through meetings with public health officials about the Australia score. Secondly, it has stimulated advocacy. Advocacy to the government involving discussions or meetings with several federal and state health ministers and departments of health. And thirdly, it has generated capacity in action, initiating constructive engagement with health policymakers, services and professional organisations. It has been pleasing to see that the WBTi Australia report has been embedded as international benchmarking with the Australian National Breastfeeding Strategy in 2019. And it has also been included in the 2019 Children's Rights Report by the Australian Health Rights Commission. And finally, we've been hosting with the Australian National University Crawford School of Public Policy, along with Save the Children, a series of webinars over the past few months focusing on human rights and breastfeeding and gender responsive budgeting, and looking at how the priority action areas of the Australian National Breastfeeding Strategy line up with the WBTi Australia report recommendations, and how they are funded and how a gender budget approach can help focus our advocacy. Approximately 375 people have registered for these webinars from different countries around the world. The first outcome of this series of webinars will be a WBTi background paper on infant and young child feeding in emergencies, which will evolve into a WBTi Australia position statement. After an Australian summer filled with massive destructive bushfires, smoke pollution and extreme hailstorms, closely followed by COVID-19, there's never been a better time to demand progress on this fundamental indicator. The least we can expect of our governments and service agencies is that they plan to help mothers and protect food security for infants and young children during a disaster. Supporting breastfeeding is supporting food security. Finally, our next webinar as part of this series on June the 29th will focus on women's health rights in maternity care. Please go to the ANU Crawford School of Public Policy website. The link is in this slide for more information. And once again, thank you very much for having me.
Nubur?
Thank you, Naomi, for the presentation. Now I would like to introduce Francesco Branca, Director, Department of Nutrition and Food Safety, WHO Headquarters, Geneva. He's going to present remarks and way forward to increase global rate of exclusive breastfeeding from 41 to 50%. Francesco Branca is the Director of the Department of Nutrition and Food Safety in the World Health Organization, Geneva. During his tenure, WHO has developed a WHO nutrition strategy, established a new nutrition guideline development process, and has developed a comprehensive implementation plan on maternal, infant, and young child nutrition with 6 global targets. He has been leading the preparation of the 2nd International Conference on Nutrition and the secretariat of the Decade of Action on Nutrition. He has been a senior scientist at the Italian Food and Nutrition Research Institute, where he was leading studies on the effect of food and nutrients on human health at different stages of life cycle and on the impact of public health nutrition programs. He has been president of the Federation of the European Nutrition Societies in 2003 and 7. Dr. Branca is a graduate in medicine and surgery, specialized in diabetology and metabolic disease at the Sacred Heart Catholic University, Roma, and obtained a PhD in nutrition at Aberdeen University. Over to you, Dr. Francesco Branca.
Thank you very much, Nupur, and hello to everybody in different parts of the world. I really welcome this assessment of the World Breastfeeding Trend Initiative. This initiative has a glorious history, and now really the fact that most countries in the world, more than half of the countries in the world, have been engaged in this process is really a testimony to its effectiveness. I would say that one of the important points that has been described in the assessment is the engagement of multiple actors, and particularly the engagement of government. We understand the challenges that this still has, and the need to even have that more, because clearly country and government ownership is going to be important for the success of policy change. But what we definitely have seen in this evaluation is that assessments help progress, and the more assessments are done, the more progress is done. I also would like to highlight the importance of granular assessment. With the World Breastfeeding Trend Initiative has 10 policy areas. And, of course, we have seen that some policy areas in some countries have progressed more than others. And even there's been a backsliding in some of the areas. But what is important is the comprehensive impact. As it's been demonstrated in the past, the higher the score, the better the breastfeeding indicators, which is really the demonstration that we can't have progress unless all those 10 areas are advanced. Now, we are frustrated by the fact that the breastfeeding globally has only marginally increased. But it's already good news that it has increased, but it's marginally increased. And we have globally set targets to reach at least half of the children by the year 2025 with exclusive breastfeeding. So as you said, Nupur, we're still far, 41 to 50. That's a long way to go. Collectively, certainly we can focus our action on a series of priorities. You're going to hear from David about the Breastfeeding Collective, which is really an important collaboration, and really the alliances are critical to achieve better progress. Now, the Breastfeeding Collective has developed a scorecard, and it identifies a series of action priorities, and let me highlight some of them. Certainly, an important one is better regulation of marketing breast milk substitutes and adherence to the Code of Marketing breast milk substitute and the subsequent resolution. We've just released jointly with IBFAN and UNICEF a report, 2020 report on the code. And this report says that there's 136 countries out of the total of 194 that have some regulatory approaches. So that's good, but it's not all the countries. So 1/3 of the countries doesn't have a regulatory approach. And we've just heard about the challenges that Australia, for example, has. But out of the 136 countries, only 25 really have full implementation of the code and 42 partial implementation. So it's also a quality issue. It's a quantity issue and a quality issues. We need to have more countries and also better regulations. What are the issues? What is not covered by these regulations? Well, the extent of the coverage of breast milk substitute marketing, it doesn't go up to 36 months. It only covers the first few months of life. Still, claims are allowed on breast milk substitute. Still, educational materials are allowed from industry. And there's a big issue of the incentives given to healthcare workers. There's still the issue of donations made to hospitals and the sponsorship of pediatric associations. So that's where an action is needed to improve the quality of those regulations. Second important area is around health systems. And we've all heard that a baby-friendly hospital initiative seems to be going backwards. That's why collectively, WHO, UNICEF, with many other actors have now promoted, with of course with the secretariat of the Baby Friendly Hospital Initiative, have promoted a new era of Baby Friendly Hospital, where really these elements of the 10 steps of to exclusive breastfeeding have to be mainstream in the quality of care of all hospitals and all healthcare centers. So that's really a challenge to make this as an integral part of our way to deliver healthcare and as part of the universal health coverage agenda. We have essential nutrition action, and of course, promotion, protection is breastfeeding is part of them. But we need to do more on breastfeeding counseling. So that's another area of expansion. Health workers need to be better trained to do that, and they need to provide better support to all mothers. We now have more experience. We have better guidance. We've issued this year some new guidance on that, but collectively we need to act on that, and we need to invest resources on that. Third area, maternity protection. And this is both in terms of paid family leave, but also in terms of workplace policies. I must say there's been quite a lot of engagement from the International Labour Organization on this, but and we've heard that some countries are making progress, but again, much more to invest. And perhaps the fourth area I would like to highlight is the need to have better community support programs to promote, protect, and support breastfeeding. Now, how do we get more action to do this? This year we have seen with great concern the risk that the COVID pandemic can push us back with more promotion of products seen by the companies, with less efficient services, even with some guidance that suggests that mothers with the disease should be separated from their children. We're saying that this shouldn't happen, but there must be, of course, vigilance and action there. But at the same time, there are a number of political processes that perhaps we can build on to get more commitments from countries. One of them is the Decade of Action on Nutrition, where in the midterm of its implementation, we're looking at the work program again, and we're trying to get really more collaboration, more alliances, more commitments around promotion, protection, and support of breastfeeding. And connected to this is the Nutrition Summit, Nutrition for Growth, where really promotion, protection, and support of breastfeeding is one of the key areas, certainly a key area connected to the implementation of health system and universal health coverage. So a lot to do, but I really would like to thank the World Breastfeeding Trend Initiative. As you said, Arun, this is actually one of the recommendation of the Breastfeeding Collective. Having good monitoring of the policies is an important tool for advocacy and to keep us on track. Thank you very much.
Thank you, Dr. Branca, for the presentation and being well in time. Now, I would like to introduce David Clark from UNICEF headquarters, New York. He's going to share about how WBTi is integrated in the Global Breastfeeding Collective and in CRC reporting. David Clark is an international lawyer working with the nutrition section, UNICEF, New York. Since 1995, David has assisted more than 60 countries in drafting legislation to implement the International Code of Breast Milk Substitutes, and has been instrumental in bringing a human rights-based approach to the protection, promotion, and support of breastfeeding. He has contributed to the development of international policy guidelines in the area of HIV and infant feeding in emergencies, and has provided guidance on issues around international trade agreements and intellectual property rights. David, over to you. You have 10 minutes.
Thanks very much, Nupur, and I have to say it's a great pleasure to be here among old friends, let's say. So it's great to participate in this, to contribute to the launch of this report, which I think is very important because it does demonstrate, I think, how effective and how useful the WBTi process is. I mean, I was really pleased to see, for example, this fact, the way that people are reporting on how this has been important in strengthening of various skills, which you mentioned, Arun, and I think that does contribute to the sustainability and contributes to our community of breastfeeding champions to be able to do our job better. And part of that, of course, is the fact that the WBTi is integrated and contributes to other processes, and I'm just going to talk about a couple of them. So I'm going to start sharing my screen.
Yes, please.
Is that working?
Yes, we can see your screen.
Okay, I'll just make it a slideshow. Okay, so let me see, how do I move from... So yeah, we've mentioned, Francesco's mentioned the Global Breastfeeding Collective. So just a little bit so that people can understand what it is. So it is a whole group of partners. I'll talk about that in a second. So we've come up with a mission to enable more mothers to breastfeeding by securing new financial resources for national breastfeeding programs and strengthening political commitment. So we're sort of working at that level to try and get the resources and the political commitment that we need in order to do the sort of work that is necessary to strengthen breastfeeding programs, policies. And of course, we also want to encourage the adoption of supportive laws, policies and tools at the global, regional and country levels. And we're doing that within the broader development, humanitarian and human rights agenda. So this is an important area. I mean, it's an important grouping of partners to come and try and achieve those. And some of the strategic goals are to foster leadership and alliances, to effectively integrate and communicate breastfeeding messages so that we are all in this community saying the same things and being clear and precise and kind of research-based, evidence-based in our messaging. The mobilization of resources and the promotion of accountability are extremely important. I think we've seen that within WBTi, the resources necessary to have the sustainability to be able to do the assessments as frequently as we need to, because we've seen that by doing them more frequently, we actually improve outcomes. So it's really important. And also the collective acts as a platform or somewhere that we can build knowledge and evidence so that we can enhance breastfeeding policies, programs, financing, and communication. So just to give you a look at the wide range and the number of partners that we have on this, of course, including IBFAN, it's guided by UNICEF and WHO, but you can see we have a whole range of important partners that can help us in achieving that mission. So Francesco also made reference to these different, the policy actions that we're calling on. The first important one, of course, is to increase funding. Second one, Francesco was also talking about the importance of implementing the code. Third one is the maternity leave. Implementation of the 10 steps. Improve access to skilled breastfeeding. Strengthen links between health facilities and communities and encourage community networks. Are you beginning to see a pattern here between what the policy actions we're doing here and what WBTi is actually monitoring and assessing? So you can see that there's a very clear synergy between these initiatives. And And the seventh one, which is important here, because it is about strengthening monitoring systems that track the progress of policies, programs, and funding towards achieving both national and global breastfeeding targets, which is exactly what WBTi sets out to do. So you can see how it's sort of embedded in here. Here we have the information on the global breastfeeding scorecard used to track these policy actions. And you can see in terms of monitoring systems, it specifically it talks about continuous tracking and evaluation of progress being such an important step so that countries can learn about the effectiveness of their work. They can learn about where they are falling behind, and that can and does, as we've seen from this report, improve outcomes, improve policies, strengthen policies, etc. So the WBTi is recognized here as an indicator whether you've done that or not in terms of this scorecard. And in 2019, we found that only 41% of countries had completed a WBTi assessment in the last 5 years. And just in case you're interested, we can also just go in a moment. And here you can see the scorecard, which you can try and find the country that you want to look at. We've got Afghanistan as the first country here. And you can see in terms of the enabling environment and reporting, down here, we have the report that the most recent WBTi set of the overall breastfeeding program was 2015. So they are graded in terms of when they have done the WBTi report. And if you go down here again, you can see that Afghanistan is towards the green here. This looks specifically at how countries are doing in terms of whether they have carried out BTI. So you can see which countries are in the red, which are in the yellow, and which are in the green. And you can do that for all of these indicators. Yeah, I'm back to this one, yeah? Okay, and another really important part is the way WBTi can help in the CRC, can and does help in the CRC reporting process. And I think Marcus showed us how that was very helpful in Mexico. And reference was made to this in the Child Rights Report in Australia. So it is indeed important. So in terms of the Convention on the Rights of the Child, and we all know that this is a legally binding international treaty. So all the states parties, all of the governments that have ratified the CRC, which is every country in the world except one. So by signing on to this, they are obligated, they have a responsibility to pursue the full implementation of the rights of the right of the child to the highest attainable standard of health, and they shall take appropriate measures. This is no longer a recommendation to them. This is an obligation that they take on when they ratify the CRC. So they have to diminish infant young child mortality, they have to combat disease and malnutrition, and the Article 24 refers specifically to the advantages of breastfeeding and the need to ensure that everybody has unbiased information and the support they need in order to successfully breastfeed. So that really brings it into the realm of not a recommendation to governments to do something, but an obligation, and that's very important. And we have the Committee on the Rights of the Child, which is the body of experts who are that has been established to monitor national implementation of the convention. So states or governments, they must report to the committee every 5 years. UNICEF, civil society organizations, and children themselves can provide additional information to the committee, and the committee examines these reports, raises concerns with the governments, or makes recommendations to the state. And it's saying to the state, basically, you're not fulfilling your obligations in this or that respect. So these recommendations are very important, and countries don't really want to go back 5 years later and not have done something that has been shown and recommended to be in the best interests of children. So IBFAN for many years now has been preparing alternative reports, and these are really important, and we have to acknowledge here the work done by the GIFA, IBFAN GIFA, which is the Geneva Infant Feeding Association based in Geneva, and therefore on hand when the committee meets to review the country progress. And they have been, and I know that the committee, because I've spoken to members of the committee who are really acknowledge how useful these reports are in helping them assess what's going on in terms of infant and young child nutrition during the reporting process. And together with WHO and IBFAN, we have 2 or 3 times over the last number of years arranged a meeting or a briefing with the Committee on the Rights of the Child to reinforce the importance of all these policies that we're talking about in protecting mothers and babies' rights, particularly their right to health. And this has really had a tangible impact on the recommendations made by the committee and on government action. So in 2014, 2015, IBFAN, the IBFAN alternative report template, which they provide to the countries around the world when they're preparing these alternative reports, it included the WBTi indicators. And that therefore gave them the opportunity to use the WBTi reports as a data source in being able to say to the committee, well, you know, they're not doing so well here, they're doing better here, or whatever. Obviously, they can only do that for countries that have carried out WBTi, and therefore it's important, even as part of this this process of implementing the Convention on the Rights of the Child, that countries do undertake WBTi. So these reports are thus able to cover all the elements necessary to ensure adequate protection, promotion, and support of breastfeeding. And we can see, if we look between 2014 and 2018, IBFAN's advocacy through these reports, through using WBTi, has contributed to 90 infant and young child feeding recommendations to the CRC committee, which then are very often translated into recommendations, which are very influential on what countries are doing, and give us a really good opportunity for increased advocacy. So I would like to just end up by saying that in addition to the benefits of implementing WBTi at the national level, which Aaron spoke, and Marcus, and I think everybody so far has spoken to these benefits that arise just from carrying out the process, but also then from using the findings, that this initiative really contributes to the mission of the Global Breastfeeding Collective. I think we've seen that. It's a very important contribution to that, and helps us, all of us in the collective who are trying to advocate for more resources, for greater responsibility on the part of the governments. The information provided from WBTi is very, very helpful in that process. And of course, the human rights-based approach, using the CRC itself, and the actual process of reporting and holding governments accountable, it really has received a great deal of help from the availability of the WBTi data in order to make these, draw attention of weaknesses to the Committee on the Rights of the Child, and the recommendations that come out as a result of that really do help to improve the breastfeeding situation and ultimately protecting the rights of mothers and babies. So congratulations on the launch of this report. It is really important, and I'm very honored to have been asked to be a part of this launch. Thank you very much.
Thank you, David. Thank you, everyone. Before we go on to ask questions, so there are a lot of questions, and many of them have been already answered by the panelists, but there are a few which I have noted down. But before we get into the question and answer round, can we just officially launch the WBTi evaluation report? I would request all the panelists to hold on their cover pages, and I would request the host to maybe take a screenshot and take a picture. Yes, so here is the official launch of the WBTi evaluation report 2020. Thank you, everyone.
Yeah, it's done. It's done. Thank you so much. Thank you so much.
Thank you. Okay. Okay, so I hope it was an informative and learning experience for all the attendees. Before I go on to the question and answer round, I would like to give some of my comments on the overall session and on WBTi. With this overwhelming participation, we can see that, and with all the presentations and everything, and a lot of questions and engagement is happening, it's quite overwhelming, and I'm happy to see all of this. And we can see that WBTi is indeed a valid tool that empowers individuals and organizations seeking policy change on IYCF at the country level. WBTi assessment reports and report cards are authentic advocacy tools based by evidence. WBTi evaluation report findings showcase how simple and sustainable changes in policy and programs have resulted in high rates of exclusive breastfeeding in many countries. Evidence from WBTi attracts policymakers' attention, and it becomes much easier for us breastfeeding advocates to argue that protection of maternal and child health through breastfeeding deserves to be prioritized and deserves investment. Now, I would like Dr. Arun to give a thank you note before we get on to the question and answer to all the panelists.
Nupur, can you get the questions first before I get
All right, I can. So there were a few questions which I could myself analyze and allocate to the person it is relevant to. But there were questions which were quite generic, so any of you can pick it up. So the first question is from Ms. Sabiha Kohli, and she wants to ask, what changes have happened over the years in terms of capacity of frontline health workers in India related to counseling and training? So I think Dr. Arun or Dr. JP maybe can answer this. I think this is an Indian context, this particular question on counseling and training. Has there been any improvement?
Yeah, there's a little improvement, I would say, little by little. So I think the documentation and the intent is visible, and there's a lot of lip service also happening, but there's a lot to do, as Francesco also put it across, that it requires a lot of analysis in that sense to find out such millions of workers in India who need training. So the level of training is in thousands, or a little multiplier of that. So yeah.
Okay. Okay, so there's this question by Anna Elisa Rin, and she must have seen the reports of Uruguay and United States, and she's concerned that these are two different developing countries, but their indicator one scores the same. So she's asking that because they're two different countries.
I have already answered her, and
Okay,
yes, it requires a detailed look at the subsets. So yeah,
okay, so
we can take the specialized questions on maternity protection policy, which David and other people are here in this specialized.
So there was one question for Dr. Branca and David, which I have noted down. I'm not sure whether they have answered it, but I'll just read it out. If they've answered it, that's okay. So it's from Alexandro Elamu. He says that WBTi remains the sole tool that helps review the progress made in implementing the global strategy on IYCF. How can we encourage UNICEF and WHO to integrate or recommend countries for a country collective effort?
Yeah, thank you, Alex. Hi. Yeah, that's a very good point. First of all, we have already made that recommendation as part of the breastfeeding collective. So we're saying monitoring is essential. Policy monitoring is essential. And we recommend the use of the WBTi tool as an element. We're using this assessment. WHO and UNICEF have periodic assessment of the progress, and in WHO, for example, we refer to the assessments of the WBTi to our global database on the implementation of nutrition action. So I think both in terms of telling countries how to do and using that methodology, and in terms of using the data themselves, yeah, we're acknowledging it, but we can certainly do more on that.
Thank you, Dr. Branca. The next question is posed to Barbara. Dr. Umesh Khurana from India asks, at Uganda, how are you developing BFHI for private health facilities? Barbara, can you hear me? I think she's not available. So maybe we can take this question later. I have a question for Naomi here. Carol from Canada is asking, do you feel having 11 people as part of your core team for WBTi assessment was too many, or was enough? And is there a minimum number that you would suggest for a core team for WBTi assessment? Naomi?
Hi, Carol. 11 for us worked perfectly. That was the number of volunteers that we had who wanted to be involved. And so we allocated one person per indicator, and the 11th person was myself as the coordinator, and I looked after the indicators 11 to 15, which for Australia wasn't much work at all because we had no data monitoring in Australia at all. So there was no work to do for indicator 11 to 15, so that was mine, and the other 10 people had one indicator each. So yes, that worked perfectly for us, given we were all volunteers working full-time jobs, and people paired up as well to assist each other on their indicators. I think a minimum number would just depend on the amount of time available to the people involved, and the amount of work that needed to be done to find the data to answer the indicators. Really, I think it just comes down to the individual country, what the minimum number would be.
Thank you, Naomi. The next question is for Dr. J.P. Dadich. It is from Irina Zakariza, and she's asking that why there's lately more emphasis on policy and program indicators only, and not on the practice indicators. Aren't the practice indicators indicate of what the policy and program indicators are effective or not? So
we all know that the practice indicators that they take time to improve. If policies and programs, they are improved, and then they will have some effect on breastfeeding practices, that may take time. So we thought that, and we are asking countries to do the reassessment every 3 to 5 years. So we thought that it will be prudent to have a comparison of policies and programs. And it's not that we are not having the practices in the reports and report cards. They are there, but now they are not being included in the scoring system. So those things are there, but basically we are looking into policies and programs only now.
Okay. Thank you, Dr. JP. So there's one generic question which any of you, if you would like to answer, can pick it up. It's a question from Nargisara Begum, and she's asking why maternity leave for working mothers is not established as universal for exclusive breastfeeding all over the world. Any of you can volunteer to answer that?
By that, does she mean why don't we have 6 months maternity leave? Is that the question?
Yeah, she's asking why maternity leave for working mother is not established as universal for exclusive breastfeeding all over the world.
Well, I mean, I think there are a couple of issues. First of all, the ILO Maternity Protection Convention and the recommendation do not call for 6 months maternity protection. That is sort of seen as a standard. Although many countries do go beyond that, there are countries that do go beyond that. Of course, it's ideal if that can happen, and we have seen countries. For example, Vietnam a few years ago had made a very successful campaign to provide evidence that of the benefits, the cost savings in terms of healthcare costs, etc. If you do implement maternity leave for 6 months. At UNICEF, we actually do provide for 6 months leave for mothers, but as I say, the ILO standard doesn't call for that. In many countries it is difficult to achieve that, which is why we have to work very hard on the mother-baby friendly policies in the workplace that allow for example, breastfeeding breaks, paid breastfeeding breaks, appropriate places for a mother to comfortably express or feed her baby if that's possible, or reduced having time off at the beginning, at the end of the day, as considered as part of the breastfeeding break, so the mother can get home to her baby. So there are other ways to do it, but in the meantime we can still work in advocating for much better, much stronger maternity leave for mothers. Over.
Thank you, David. Thank you for answering that. Do we have Barbara with us? Is she connected with us again?
Yes, I'm around.
Yeah, Barbara. So there was a question for you. I'll just repeat it once again for you. So Dr. Umesh Khurana from India asked, at Uganda, how are you developing BPNI for private health facilities?
We are working with government using the BPNI tools that were developed or adapted from WHO. And then we work with the private facilities to adapt them. We train them for them to implement the steps, and thereafter we monitor them. So it's the same process as the public facilities. It's not different. No difference. Thank you.
Okay. Thank you. So,
Nupur, there are a few questions which are common on BFHI for Francesco. If you can answer that. A couple of questions, Francesco, on how can countries revitalize the BFHI? And related question is, what is the motivation incentive for the health workers to actually, move into BFHI? So there are a couple of questions of this nature.
Yes, they were there, and there's one more question on Global Breastfeeding Collective, I think, which both Dr. Priyanka and David can answer. So Helen Crowley is asking whether Global Breastfeeding Collective for international organizations, do you have an observer groups?
So I'll, first of all, I'll answer on the baby-friendly hospital initiative. It's really critical. The history of the initiative is that there have been basically secretariat and bodies ensuring certification in countries. But unfortunately, this has not been happening in the majority of countries. This has been particularly happening when there were active groups and it hasn't been a little bit biased towards the higher income countries. So we've had really very few lower middle income countries with this. So we really thought that we should really move towards a system whereby the points of the 10 steps of exclusive breastfeeding should become an integral part of the quality of care in any hospital in the world. So it's basically linking it to any public certification programs. So that would be the objective. There's still a long way to go to achieve that, but it's basically trying to combine the traditional certification scheme with certification schemes that are run by governments. On the breastfeeding collective, perhaps I'll ask David to comment, but we certainly believe that we should find ways to have as many groups as possible, both from civil society and academia, professional organization, joining forces to promote, protect, and support breastfeeding. So, yeah, any way to do that is definitely welcome.
Francesco, there's a quick question just come up when the WHO BFHI training material will be out.
I think they're done. So it's a matter of a few weeks. So we have also the counseling guide, which is finished. So it will be available in a matter of weeks. There was another point also on how to motivate more health workers of baby friendly hospital, and that's really connected to training and to the capacity building. WHO is now opening a WHO Academy. One of the components of the training hopefully will be around the code of marketing breast milk substitute. So, the target is very ambitious to reach 10 million health workers in the world in the next 5 years. So yeah, we'll try to put our effort to make that happen. Thank you.
Yes, I mean, just to add to what Francesco said, I mean, we definitely are very keen to attract members to the breastfeeding collective. I don't think we have I think you're a member, you're not a member. I'm not sure we have observers to it, because we want people who are part of the collective to be actively part of it. Groups can apply, organizations can apply. You will have to pass a conflict of interest test, because obviously that's something really fundamental, and it should be fundamental to everything that we're doing. I know it came up in some of the presentations, but this collective must be free of all commercial influence. So get in touch if you're interested.
Yes.
Okay.
Yeah, so there was one generic question which is related to the current pandemic, and people are generally asking everyone that how do you keep the breastfeeding advocates and staff motivated during COVID times, and is there any specific thing which WHO is doing to reach the breastfeeding, the communities for breastfeeding specifically? Yeah, if we can't hear you, Dr.
I think Francesco just wrote that he has to go. He has to sign off, and maybe he's there. Okay, yeah, yeah. Ask your questions, Nupur, quickly, and then Francesco has to leave. Maybe then we have to close out.
This is the last question we can address because it's relevant in current times. Attendees are interested to know that how do you keep the breastfeeding advocates and staff motivated in these times?
Well, I mean, the UNICEF and WHO has been active in, first of all, giving the message that breastfeeding promotion, protection, and support is critical. Services shouldn't be disrupted. The disruption of services is going to have major consequences. I mean, we expect a crisis that follows the pandemic, crisis which is linked to the economic crisis, but is also linked to service disruption. If you go to the UNICEF website, you see the monitoring of the service disruption is pretty dramatic. I mean, health workers, it's not because they're not motivated, because they're deployed to do something else. And also because people don't go don't attend health services because they can't move, because they're afraid. So there is that kind of disruption is a problem. So I don't think it's necessarily an issue of motivation. It's an issue of making the health services functional even at the time of emergencies. We're giving this strong message. There's this, as I said, joint FAO-WHO guidance on the continuity of services that has to take place in absolutely. We're about to launch a call to action, particularly on the response to the food security and nutrition crisis, and of course, breastfeeding, promotion, protection, and support is at the heart of it. If we don't do anything, we're going to have additional, we estimate, more than 6 million children going into acute malnutrition. That's a disaster. That's unacceptable. I must say, most of those children are going to be in India or in South Asia. So, the continuity of services must be a very strong message that we give to all those who are planning for health services.
Thank you. Thank you. Dr. Arun, would you like to thank the panel?
First of all, I like to thank you all, the speakers, Francesco, David, Marcos, Barbara, Naomi, JP, and thank you very much, Nupur and Yashika at the back end for conducting this session. And we have taken 15 minutes longer than what we thought, but I'd like to thank all the participants who have joined and spared their time, early hours of the morning, and some people late night for others. So really value your participation. We apologize for not being able to answer all the questions. We have tried many of them, but we will certainly get back to you on the questions asked through emails. And you can continue to send an email on BPNI India@gmail.com in case you have more questions, and we will try and answer that. And thank you everyone for your support to WBTi, and we'll continue to follow our relationship both with within IBFAN as well as WHO and UNICEF. Thanks a lot once again, and over to you.
Thank you, everyone. If anybody would like to give some goodbye remarks, our panelists. We don't have much attendees asking questions there or wanting to, ask
No, I'm sorry to interrupt. Actually, there are few attendees. They have some questions. Can I allow them to speak? Can they ask?
No, time doesn't permit us to do that, Yashika, because it will take long time unless we all commit ourselves to spend more time, because if we allow 7 people to speak and answer, it will take half an hour more.
Yes.
So, yeah, but we will answer the questions if people ask. We can certainly answer that.
Okay. So thank you everyone for attending, all the attendees, and we have a good turnout. So we had around 200 people attending it through the end since it began, which is a good turnout. And thank you all the panelists for being here and for all the prompt responses which you gave to all our requests and queries and exchange. It was a pleasure. It was a great experience, and we would be in touch for such future engagements with you. Thank you.
Thank you.
Bye-bye.
Thank you, Nupur. Bye-bye.
Thank you.
Bye. Thank you.
Thank you so much, everyone. Goodbye. Bye.
Bye.